Hello friends. Hello friends. So today we'll be discussing about malignant melanoma. Before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, which are very helpful for revision. And before starting, the link for the notes is given in the description below. You can download it from there. And without further delay, let's get started. So malignant melanoma arise from melanocytes, which are cells in the skin, mucosa, eyes, leptomeninges, and these melanocytes arise from neural crest, that is the embryological origin, and skin, it is present at the epidermal dermal junction. Mucosa, it could be oropharynx, nasopharynx, proximal esophagus, anorectum, and genitalia in female. And in the eyes, it is choroid or retina, and also leptomeninges. So mucosa, that is the epithelium of the respiratory, GI, and the GU tract, genitourinary tract. So it can arise from any of these sites. So the basic epidemiology, that is, it is accounts for the 2% of all skin cancers, and after the most common basal cell and squamous cell carcinoma. But important is that it causes 80% of all skin cancer deaths. So it is aggressive and deadly, that is to be understood. Incidence increases with age, and less than 50, it is more common in female, 1.7:1, and after 70 it is more common in males, less than 50 more common in females, 1.7:1, and more than 70 it is more common in males, 0.4:1. So overall lifetime risk is more in males, that is 1.5:1. Now the risk factors, the skin type is common risk factor, that is Caucasians have higher risk as compared to African American, that is 20 times, and 5 times to American Hispanics. And most common Fitzpatrick skin types, that is 1 and 2, that is pheomelanin predominant phenotype. So pheomelanin predominant phenotype, that is Fitzpatrick skin type 1 and 2, that is red, blonde hair, blue eyes, these people. So second is the UV radiation. So intermittent exposure of intense UV radiation, intermittent exposure gives rise to melanoma, whereas chronic exposure gives rise to non-melanoma skin cancer. Now we have UVA and UVB. UVA has longer wavelength, greater depth of tissue penetration, and is the predominant wavelength used in tanning beds. And UVB has shorter wavelength, damage to more superficial epidermal layers, and cause sunburn. And this is the natural sunlight. Albinism increases susceptibility to UV radiation, causing melanomas. Now, previous melanoma increases the risk of second melanoma by 3 to 7%. Family history and genetic predisposition, 10% of patients with family history of melanoma. Family history of melanoma increases risk by 3 to 8 times. So, previous melanoma and family history, sorry, increases risk by around 3 to 8%. And high penetrance susceptibility gene, that is CDKN2A, involving chromosome 9p21, which encodes cyclin dependent kinase inhibitor 2A, and have a chance of 25 to 40% chance of familial and melanoma. Other is the CDK gene, which encodes cyclin dependent kinase 4 on the chromosome 12, and it is important for G1 phase of the cell cycle. Now the other genes, that is xeroderma pigmentosum, which is for DNA repair, defective DNA repair, and increased UV radiation sensitivity, and BRCA2. Next is immunosuppression, that is due to solid organ transplant, hematopoietic cell transplant, HIV. Now some precursor lesion, Most of the melanocytic nevi are benign, but 10% melanomas arise from pre-existing nevus, and these arise de novo. So what are these precursor lesions? That is familial atypical mole melanoma syndrome, also known as familial dysplastic nevus syndrome or BK mole syndrome. Here we have melanoma in more than one primary or second degree relatives and large numbers of melanocytic nevi, more than 100, which are atypical more than 5 mm, with or without family history of pancreatic cancers. Then giant congenital nevus of size more than 20 centimeter, they have a lifetime risk of melanoma and risk of sarcoma. So these are the increased risk, lifetime risk for melanoma and sarcoma. So atypical spitzoid nevus. So atypical more than 10 mm, more than 1 centimeter, asymmetrical, ulceration, poor circumscription. These are rapidly growing pink brown benign skin lesion, spitzoid, rapidly growing pink brown benign skin lesion, and hard to distinguish from spitzoid melanoma, so they may need sentinel lymph node biopsy. So now seeing the pathology, pathogenesis in short. So in 70% of the cases, there is no identifiable benign precursor, and gain of function mutation. In 30%, there will be benign melanocytic nevi causing dysplastic nevi causing primary malignant melanoma with rapid growth phase. And some mutation, that is gain of function mutation, that is in the B MAP kinase pathway through the BRAF CDKN2A gene, or loss of P10 function. Now, the radial growth phase in the primary malignant melanoma, which is absent in the nodular melanoma, which is a type, and the radial growth phase, that is the proliferation of the neoplastic melanocytes above the dermoepidermal junction with focal invasion of the papillary dermis. It is also associated with autonomous proliferation, aggressive growth is absent, and radial growth phase, these point have lack metastatic potential, so less chance of metastasis. Then these can convert to from radial growth phase to vertical growth phase, primary malignant melanoma with vertical growth phase. These are aggregative growth, positive extensive dermal invasion, and expansile nest of or nodules of cells. So these will be causing dermal invasion, and later they will turn into metastatic malignant melanoma. So initially there will be radial growth, then vertical growth, and then metastasis. And only 30% will have precursor lesion, 70% will not have precursor lesion, and nodular melanoma will directly have vertical growth phase and no radial growth phase. Now we'll see the mode of spread. So these are usually lymphatic spread which precedes the hematogenous spread. So melanoma will have lymphatic spread causing satellite lesion, that is skin subcutaneous lesion within 2 cm of the primary tumor, represent intralymphatic extension of the tumor, so through the lymphatic. And they will also have in transit lesion, that is more than 2 cm from the primary tumor but not beyond the regional lymph node basin. So one is satellite lesion, then other is in transit lesion, where more than 2 cm from primary tumor but not beyond the regional lymph node basin. Then the regional lymph node basin, hematogenous spread, that is distant mets to the skin, subcutaneous tissue, lungs, liver, brain, and other organs. Now we see the pathological subtypes in short detail. The most common is the superficial spreading melanoma, and these are the most common cutaneous melanoma, account for 70%, seen in middle age, and 25% of these will be having pre-existing nevus, that is benign dysplastic nevus, associated strongly with the UV radiation, commonly seen in upper back of both gender and legs of female. Then they have radial growth phase before it becomes invasive. And lesion, how are these appearing? These are flat, irregular border, have pigmentation with area of regression. Invasion usually heralded by the ulceration. So it will start ulcering and then it will become invasive. HP will be showing uniformly atypical melanocyte with pagetoid distribution, and also it is therefore known as pagetoid melanoma. The second most common is the nodular melanoma, that is second most common, more common in males 2 times, and it accounts for 15 to 30% of all melanoma and common in old age people, and generally allies de novo and has very bad prognosis, poor prognosis, and weak UV radiation association, seen in trunk and head neck region. So it is above. Relatively lacking radial growth phase as we have seen. So early vertical growth phase. So it will be aggressive. Therefore, it is having poor prognosis as can be understood. Lesion, there will be short history, better demarcated. So due to relatively lack of horizontal spread, papule nodule and protuberant, there could be ulceration, bleeding. So there will be cohesive aggregate of tumor cells filling the dermis in the histopathology, and 5% are melanotic but stain positive for tyrosinase. This is the added point. Next is the acral lentigus melanoma. So most common melanoma in Asian and blacks. So commonly in the darker skin, median age is 65, advanced at the time of diagnosis. UV radiation positive history. Site is palm, sole and subungual region, that is the acral regions as we know. Then radial growth phase precedes vertical growth phase, and lesion is subungual melanomas in the great toe thumb, Hutchinson sign, pigmentation of the posterior nail fold. Histopathology will be prominent acanthosis, thickening of stratum corneum, Paget distribution, intradermal nesting, dermoplasia, neotropism and angiotropism. Dermoplasia, neotropism and angiotropism is the feature of acral lentigus melanoma. Now lentigo maligna melanoma, that is 4 to 10% in the sun exposed area, old age that is 6 to 7 decade. Overall best prognosis, strongest associated with UV radiation. Site is face and other sun exposed areas. Slow growing, prolonged radial phase, that is 5 to 50 years. Lesions are large with 3 to 6 centimeter, tan brown macules, slow progression. Invasive counterpart of lentigo maligna, in situ melanoma or Hutchinson melanotic freckle, and histopathology will have melanocytic pleomorphism. Next is the dermoplastic melanoma, around 1%, very rare, sun exposed area, old age, more common in males, associated with dysesthesia, nerve palsies. Site is head neck, can be amelanotic. Lesions are nodular, firm, scar-like. HP histopathology showing desmoplastics, splending stroma, melanocytic dysplasia, and propensity for perineural invasion and lymphatic spread. Next is we'll seeing the clinical features. So first is the ABCD rule of suspicious pigmented lesion, which can be applied for skin tumors. That is, A is asymmetry, so any lesion with asymmetry. 2 is border irregularity. 3 is color variegation, that is pigment is not uniform. Variegated pigments, diameter more than 6 mm, that is around half centimeter. Elevated, evolving and enlarging lesion with ulceration or bleeding. So ulceration, bleeding in a lesion is always a suspicious lesion. Now the satellite nodules or in transit mets showing erythematous pigmented amelanotic nodules, symptom of metastasis. So these are some of the clinical features which have to be considered. Now evaluation, thorough physical examination from head to toe, dermoscopy, pigment network, that is regular will be benign, irregular will be dysplastic or malignant, broad pigment that is early melanoma. So in pigment we'll be showing for black dots and pseudopods. Melanoma will be having radial streaming. Now biopsy, small suspicion lesion, we can go for excision biopsy, that is full thickness excision up to the subcutaneous tissue with a margin of 1 to 3 mm to avoid wider margin to permit accurate lymphatic mapping. Larger lesion or lesion on face, palm, soles, ear or distal digits, we go for incisional biopsy or punch biopsy. Tangential biopsy is not preferred. Punch biopsy, we take at least 4 mm through the thickest area, not the edge. Immunohistochemistry, HMB45, S100, Vimentin, melanin A, SOX10. Imaging, that will be nodal basin, USG for stage 1 and stage 2, followed by sentinel lymph node biopsy, cross-sectional imaging, CT, MRI. METs considering chest, abdomen, brain, CT and MRI. Now the staging, we have various levels or grades given by the Clark's level by the Wallace Clark and Breslow's thickness by Alexander Breslow. So Clark's level, that is 1 to 5, where 1 is intraepidermal, 2 is invasion into the papillary dermis, 3 is filling the papillary dermis, 4 is involving the reticular dermis, and 5 is involving the subcutaneous tissue. So extent of invasion into different layers of the skin. So epidermis, papillary dermis, reticular dermis, and subcut. So 2 and 3 are papillary dermis. Now we'll be seeing the Breslow's thickness, and it is also related to TNM staging of the tumor. So the Breslow's thickness, T1 is involving 1 mm, T2 is involving up to 2 mm in the papillary dermis, T3 is 2 to 4 mm involving the papillary and the reticular dermis, and T4 is more than 4 mm. So it depends from T1 to T4 depending on the depth of invasion from the granular cell layer of the superficial part. And T1 is 1, T2 is 2, T3 is 2 to 4, and T4 is more than 4. So if it is less than 1, it is called thin melanoma. 1 to 4 mm is intermediate melanoma, and more than 4 mm is thick melanoma. So we have to consider this. So T1 will be thin melanoma, T2 and T3 will be intermediate melanoma, and T4 will be thick melanoma. So AJCC staging, T0 where no evidence of primary tumor, TX where tumor cannot be assessed, TIS melanoma in situ. T1 less than 1 mm, as we have seen, it is divided into A and B. Less than 0.8 mm without ulceration, that is A, and B is less than 0.8 mm with ulceration, or 0.8 to 1 mm with or without ulceration. Now T2, that is 1 to 2 mm, T1 without ulceration, T2A without ulceration, T2B with ulceration, T3 2 to 4 centimeter, A will be without ulceration, B with ulceration, T4 more than 4 mm, A will be without ulceration, T4B with ulceration. So this was the T. Now the N1 will be one positive node or satellite nodule or in transit metastasis, and divided into A, B and C, where A is clinically occult, positive by sentinel lymph node biopsy, B is clinically positive, C is satellite nodule or in-transit mass. N2 is 2 to 3 nodes positive or satellite nodule or in-transit mets. Again, ABC similarly to N2A, clinical occult, sentinel lymph node biopsy positive, clinical N2B, N2C will be satellite nodule or in-transit mets with 1 node positive, N3 more than equal to 4 nodes positive or satellite node or in-transit mets, and again divided into A, B and C, where A is clinically occult, positive on sentinel lymph node biopsy, and 3B is clinically positive with any number of matted nodes, and 3C is satellite nodule or in-transit mets with 2 or more positive lymph nodes. The metastasis, M no distant mets, M1 divided into A to D for better prognostic staging, where A is skin, soft tissue, muscle, non-regional lymph node, B is lung, C is non-CNS visceral sites, and D is CNS visceral sites. It will be also marked with LDH, or which is normal or increased with added points. Now the stage grouping, where 0 is tumor in situ, stage 1 where we have 1A with T1A that is less than 0.8 mm, stage 1B that is T1B 0.8 to 1 mm, stage 2A, so T1B and T2A will be stage 1B. Then stage 2 is divided into A, B and C, where stage 2A will be T2B and T3A, stage 2B will be T3B and T4A, and stage 3B will be T4B. Stage 3 will be NET with N1 or more, and stage 4 will be M1. So up to T1 and T2A it is stage 1. From T2B to T4B it is stage 2, and N1 is stage 3, M1 is stage 4 in short. So this was about stage grouping. Now we'll see the prognostic factors. So it depends on the primary lesion, that is tumor thickness and Clark level. Ulceration will have aggressive biology, mitotic rates, increased mitosis, decreased survival, and especially in melanomas less than 1 mm, tumor infiltration lymphocyte, that is host immune response, will have favorable prognosis. So the immunity is fighting against the tumor. Regression, that is partial or total obliteration of the melanoma due to host immune response, which could be either cytokine, humoral or cell mediated, and is seen in microinvasive or thin melanoma, and seen as focal or partial or rarely complete regression of the tumor, uncertain whether it represents a favorable or adverse outcome. So that's a debate. Then the nodal metastasis and intralymphatic spread, again it will be sign of poor prognosis. Metastasis, non-visceral metastasis will have better prognosis than visceral metastasis involving the organ is always bad. Elevated LDH will have poor metastasis. Skin subcutaneous mets, chances are 40 to 57%. Lungs will have 18 to 36%, liver 14 to 20%, brain 12 to 20%, and bone 11 to 17%. other factors like the age, male gender, axial lesions, and vascular lymphatic invasion. Now coming to the management of the cutaneous primary melanoma. So we go for full thickness wide excision down to the muscle and fascia, where we go for tumor thickness with less than 1 mm. We have a 1 centimeter surgical margin. 1 to 2 mm, that is T2, will be having 1 to 2 centimeter margin, and 2 to 4 and more than 4 will go for 2 centimeter margin. So no evidence that the margin more than 2 centimeter are beneficial. So if it is more than 2, it is no beneficial. There's no evidence for that. But greater margins may be considered for advanced melanoma when local recurrence risk is high. So we can take more margin if we are considering risk of recurrence. So melanoma in situ, wide local excision with 5 mm margin. We can also go for Mohs micrographic surgery, but it is controversial. It is used mainly for non-melanoma skin cancer and can be used for thin melanoma or melanoma in situ, especially in the sensitive area like the face. Subungal melanoma, we go for partial digital amputation with 1 centimeter margin. So this is special point that needs mention, that is partial digital amputation with 1 centimeter margin in the subungal melanoma. Now the lymph node management for the melanoma, that is we go for sentinel lymph node biopsy, as the risk of lymph node metastasis is directly proportional to the melanoma thickness. More the thickness, more the risk. And status of the sentinel lymph node is the single most important factor in the melanoma patient. So it will be helpful for the assessing prognosis. So what are the indication of sentinel lymph node biopsy? If it is thick melanoma, that is more than 4 mm, T4. Thin and intermediate melanoma with other adverse factors like ulceration, more mitosis, more than 1. Other factor like Clark level 4 or 5. Again comes to thickness, patient with young age, less than 40, male gender. Even in thin melanoma, risk of metastasis is higher when the size is more than 0.75, that is in the T2, T1B, that is 0.8 to 1 centimeter. And we may consider sentinel lymph node biopsy in solitary resectable in transit metastasis also, that is involving the node in the basin, within the nodal basin. Then the procedure of the sentinel lymph node biopsy, we go for pre-op lymphoscintigraphy with technetium-99 sulfur colloid of 0.5 millicurie injected into the dermis of around 0.5 centimeter away from and around the lesion 2 to 4 hours before surgery. Then we identify the sentinel lymph nodes with the gamma camera. And intraoperatively, we use blue dye, vital blue dye, that is isosulfan blue, injected in the similar fashion. And 1 to 5 ml is given. After 20 minutes, we check, it gives hot blue nodes. So sentinel node is the most radioactive node in the nodal basin. Any node with more than 10% activity as the most radioactive node in the nodal basin, and any node that is blue. So all these will be removed and considered. So what are the ways of lymph node dissection? We have three, that is elective, total, and completion. So we'll see one by one. That is elective lymph node dissection, ELND, performed on patient without clinical evidence of nodal mets, and in patients without palpable nodes, imaging study suggestive of nodal disease. So it has no added survival benefit. Role of elective ilioobturator lymph node dissection among patients with positive inguinofemoral nodes, more than 3 Cloquet node, without clinical evidence of ilioobturator pelvic node involvement. So this is controversial. Ilioobturator lymph node dissection. Now the total lymph node dissection, that is lymphadenectomy for nodal base disease dissected on palpation or imaging. So lymphadenectomy is limited to the nodal basin which nodes are positive. Here we have various axillary, neck, inguinofemoral dissection, that is superficial, deep, ilioobturator pelvic dissection. And lastly, the completion lymph node dissection, CLND, where it is performed lymphadenectomy for nodal disease detected by the SLNB. So here lymphadenectomy is limited to the nodal basin in which the nodes are positive. So it is similar, either clinically in the total or SLNB in the completion. So here again we have same axillary, neck, inguinofemoral dissection, superficial and deep, ilioobturator, pelvic dissection. Now we see the complication of these lymph node dissection, that is delayed wound healing of the site, wound infection, lymphoma, lymphedema and seroma. Management of the in-transit metastasis. In the absence of disseminated disease, if it is resectable, we go for resection with curative intent. If it is unresectable, we have isolated lymph perfusion, and it can also be treated like a metastatic disease. In isolated lymph perfusion, that is we go for HILP, that is hyperthermic isolated lymph perfusion, which improves the cytotoxicity of the chemotherapeutic agent. Here we go for first formal lymph node dissection, expose the vessel, cannulate the vessel, and placing the limb on ECMO, that is extracorporeal oxygenated bypass circuit, after application of tourniquet, isolation of limb from the systemic circulation, and then we administer the chemotherapeutic agent, that is melphalan. And here we can also administer higher dose of cytotoxic agent with and also avoid the systemic toxicity. Along with that melphalan, we can also give actinomycin D and TNF alpha. Isolated limb perfusion infusion is a similar technique with simpler and less invasive compared to isolated limb perfusion, performed percutaneously under radiological guidance, and there is no lymph node dissection done prior, there is no oxygenated circuit, and it is done through main artery or aneurysm of the unaffected limb, which is given to the affected limb through the pneumatic tourniquet, and infusion of the cytotoxic agent and hand circulation using a syringe done for 20 to 30 minutes, and progressive hypoxia acidosis, which will improve the cytotoxicity of the melphalan. Now the multimodality approach, that is radiation, but since melanoma is relatively radio resistant, we have to think whether it is needed or not. Radiation therapy, that is EBRT in the form of IMRT or IGRT. Then radiation to the regional nodal basin, that is 50 to 60 gray. It is given when there is more than positive nodes, more than one in parotid, more than two in cervical axillary, more than three in inguinofemoral, bulky disease, lymph node more than 3 cm in cervical axillary, more than 4 cm in inguinofemoral, extranodal soft tissue extension. For the primary radiotherapy with the high risk of local recurrence in select cases of around 60 to 65 gyri. So it is given in positive or closed surgical margin when resection is not feasible, location of head neck, extensive neurotropism, pure dermoplastic melanoma, locally recurrent disease, definitive radiotherapy of 60 to 70 for in situ melanoma or lentigo maligna in medically inoperable disease. So definitive radiotherapy can also be given since it is inoperable. And in transit disease with definitive or palliative intent, then radiotherapy for distant mets, brain mets through stereotactic radiotherapy or radiosurgery, or whole brain radiotherapy, extracranial mets through stereotactic body radiotherapy. Now, systemic therapy in melanoma, that is immunotherapy, targeted therapy, and chemotherapy. Immunotherapy can be adjuvant in patient with positive lymph nodes, primary more than 4 mm without ulceration, more than 2 mm with ulceration. Drugs are interferon gamma 2 beta. sorry, interferon alpha it is. Interferon alpha 2 beta, pegylated interferon alpha 2 beta, ipilimumab, that is CTLA4 blocking antibody, ipilimumab, nice to hear. Metastatic melanoma, that is PD1 blocking antibody, that is pembrolizumab, CTLA4 antibody, that is ipilimumab, and talimogene, intralesional, and interleukin 4. Then targeted therapy, that is BRAF inhibitors, that is dabrafenib, MEK inhibitor, that is tramatinib, BRAF and MEK inhibitor combined, c-KIT inhibitors like imatinib. Then the chemotherapy for metastatic melanoma, it is done for progressed who have progressed even on immunotherapy and targeted therapy. So drugs like dacarbazine, temozolomide, that is oral analog of dacarbazine, then paclitaxel, and platin, nitrosurias, zinc alkaloid, and taxane. These can also be used. Then nevi, that could be intradermal inside the dermis. Example of nevus of Ota, blue nevus, Spitz nevus, halo nevus, junctional nevus, and compound nevus, where it is having junctional proliferation of the melanocyte and dermal nest of melanocytes below. That is the compound nevus. And non-cutaneous melanomas, just a brief, that is ocular melanoma. It has hematogenous spread in liver. It lacks lymphatic vessels in uveal tract, so no lymphatic spread. Treatment is done by enucleation, I-125, brachytherapy, photocoagulation, and partial resection. And the mucosal melanoma, it can involve head, neck, oral cavity, oropharynx, nasopharynx, PNS, anorectum, female genitalia, and will need resection. So this was all about malignant melanoma, a very big topic. Hope it will be studied easily through the notes. And thank you for watching. Please like, share, and subscribe. Keep studying, keep growing. Never give up, because great things take time. And thank you for watching. See you in next video.